Knee pain is one of the most common complaints among athletes, active individuals, and even those who don't engage in high-impact activities. Do all tears require surgery? So when is surgery necessary? Hello and welcome back to another episode of the Soft Tissue OT podcast. My name is Jordan, the Soft Tissue OT, and today's episode is all around the knee and the knee meniscus. So knee pain is one of the most common complaints among athletes, active individuals, and even those who don't engage in high-impact activities. And it's one of the most frequently injured structures in the knee is the meniscus. Now, this is a fibrocartilaginous shock absorber that plays a critical role in knee stability and knee function. But what happens when the meniscus is injured? Do all tears require surgery? Well, most research shows that many meniscus injuries can be successfully managed without surgery and with non-operative rehabilitation, showing very promising long-term outcomes. So in today's episode, we'll break down the anatomy and the function of the meniscus, how meniscus injuries occur, the different types of tears, and how to best rehab them. We're particularly going to be focusing on the growing evidence supporting non-operative rehabilitation. So let's get started. To understand how meniscus injuries occur, we need to first appreciate its structure and role in the knee. Now, in each knee, there are two menisci, and we've got the medial meniscus, which is a more C-shaped and attached to the medial collateral ligament of the knee, and it makes it a little bit less mobile and therefore a little bit more susceptible to injury. Then we've got the lateral, meaning the outside, more circular and mobile. This reduces its likelihood of injury compared to the medial meniscus. So what's the primary function of the meniscus? Well, primarily they're to absorb shock. So they distribute about 50 to 70% of the weight-bearing forces across the knee joint, and they're to provide more joint stability. So they enhance the congruency between the femur and the tibia, reducing shear forces. So the meniscus itself actually helps to make the knee joint deeper, if that makes sense. So it creates a little bit more of an actual joint rather than just bones sort of floating around. It's also there to load transmit, right? So helping to distribute the force of the load that comes through that knee. And there's research shows that without an intact meniscus, the peak contact pressures in the knee increase by 235%. This has been linked to accelerated cartilage wear and increasing risk of osteoarthritis, and that was done by the researchers McDermott and Armis in 2006. And then lastly, one key role that often doesn't get spoken about is proprioception. So meniscus play a key role in knee joint awareness and neuromuscular control. And it's helping us to basically feel, for lack of a better word, where our knee is in space and in relationship to the rest of our body. That's basically what proprioception is talking about. So how do meniscus injuries occur? We like to divide them into two categories, and we say through acute trauma or degenerative processes. Okay, so if we dive into the acute meniscus tears, we typically see them in athletes or active individuals, and they often occur from rotational forces. And this particularly occurs when the knee is in flexion and the foot is planted. Now, the tricky thing with these is that they are often associated with anterior cruciate ligaments, or ACL, injuries, and they occur in up to 50% of ACL ruptures. And that's what's shown evidence of research by Shelbourne et al. In 2016. And that's because the actual meniscus, particularly the medial meniscus, attaches or links in, I should say, with the ACL, as well as your medial collateral ligament. So that's what we call the unlucky triad or unhappy triad, is when you do your meniscus, ACL, and medial collateral ligament. And because they're linked together, and also because of the mechanism of force placed through the knee when you do these type of injuries, you can very often get one or two or three of those structures involved. And obviously that becomes a lot more, or can be a lot more complex in the rehabilitation if we're involving multiple structures. But that's generally what we call the unlucky or unhappy triad. Now, the other category that we divided into is the degenerative meniscus tears, which is more common in your older population, so 40, 50 years and above. And this is thought to generally occur due to the progressive breakdown of collagen and proteoglycans within the meniscus. Okay, so this one typically presents with more of a gradual onset. You'll get some swelling, some intermittent knee pain or catching as well. And there is a big link or coexisting of mild to moderate knee arthritis as well with these type of more your degenerative tears. So those are the two sort of buckets or categories that we put there, the ones in acute and then your more degenerative changes. Now, in terms of the type of meniscus tears, it's quite important to keep in context the type of tear, because it does sort of guide the rehab, also guides where the tear obviously is, but also what you need to do to rehab it. So we'll cover a few of them, not all of them. There's not an extensive list by any means, but a few of them, or the most common ones, is what we call, firstly, a bucket handle tear or longitudinal tear. This type of tear runs parallel to the outer rim of the meniscus, similar to like how a handle of a bucket attaches to the bases on either end, and we've got this sort of gap in between. If the torn portion flips into the joint, this is where it can become very provocative, because it can often lead to knee locking in place or catching. That can be very painful. Next, we've got a radial tear. This tear extends from the inner free edge of the meniscus towards the outer rim, much like a spoke on a bicycle wheel. That's what we're thinking about when we think of radial tears, and they disrupt the hoop stress distribution of the meniscus. Right, which is important for the ability to absorb shock, is hoop stresses. And when we have that type of tear, that disrupts the flow of that stress, and therefore can lead to further issues. Next, we've got a horizontal or cleavage tear. This type of tear splits the meniscus into an upper and lower section, similar to like if you grab a hamburger bun or hot dog bun and you cut it in half. That's separating the two, and these tears are more common in degenerative cases. And they can also lead to, particularly in this case, a more intensive fluid buildup or accumulation in the layers of the meniscus, because obviously you basically open up, as we're saying, that sort of half bun, and that's where we can get a accumulation of fluid in between those two tear pieces. And then lastly, a complex tear, which is a combination of different tear patterns. So you can have one, two, or multiple. So often involves like a radial tear, horizontal, and oblique components. And these tears generally occur in more chronic cases. And they can make surgical repair more challenging as well. Then lastly, we've got our flap tear. This tear creates a loose flap in the meniscal tissue, so literally like a flap, which can then fold over into the joint space and cause mechanical symptoms like catching or locking. And it resembles almost like a small tab of your paper, the end of a book folded over, and they can intermittently obstruct normal knee movement and normal knee function. So, non-operative rehabilitation. For decades, the arthroscopic partial meniscectomy was the go-to treatment for meniscus tears. However, recent high-quality studies have challenged its necessity in many cases. So, Katz et al. In 2013, they conducted a randomized control trial, and they found that physical therapy, or physical rehabilitation, alone produced similar outcomes to surgery in patients with meniscus tears and mild osteoarthritis. Another study, Seehoven et al. 2013, and the Fidelity trial, landmark RCT, randomized control trial, demonstrated that sham surgery had the same outcome as real meniscectomy. So a sham surgery is when they actually don't perform the operation. They sort of just cut the patient's skin, so they think they've had the surgery, but they don't actually do anything, into the actual joint or anything to do with meniscus. And that had similar outcomes or the same outcomes as a real surgical intervention. Okay. Van der Graaf et al. In 2018, they compared surgery versus physical therapy and found that rehabilitation alone was equally effective at a 12-month follow-up, which is crucial because we're not just looking at short-term, we're also looking at longer term, so like 12-month follow-up. So that's just an example of some of the research. There's a lot more out there, but this was more of the pronounced research that was into it. And so non-operative rehabilitation is becoming more of the go-to. Now, don't get me wrong, there is a time and a place for surgery, like most surgeries or all surgeries, for the right person, at the right time, for the right reason. I'm all for surgery. But non-operative is becoming more of the norm, which is good to see because, again, obviously surgery itself comes with its own risks. But to sort of dive into that a little bit more in the rehabilitation approach, let's dive into specifically about the non-operative rehabilitation. So this type of approach focuses on reducing pain, improving neuromuscular control, and enhancing knee function. So I've sort of broken it down into a couple of phases here. Now, obviously, keep in mind every person's different, so context is key, but this is a rough outline that we like to follow. So phase 1 is about pain and swelling control. And this is generally about 1 to 3 or 1 to 4 weeks into the rehab process. So we're thinking about unloading the knee against aggravating activities. So we still want the patient to move, we still want the knee to move, but try and reduce aggravating activity. So, for example, twisting the knee, rotation components, often very triggering for meniscus injuries. We want to try and avoid those. Then we like to introduce some isometric quadricep exercises. So this helps to maintain muscle activation without excessive stress on the knee. And then you can also use things like compression. Sometimes people like to use heat as well, and that's just to sort of manage the swelling itself. So that's generally 1 to 3. And then moving into the next phase, which is between weeks 3 and 8. And this is what we refer to as the strengthening and stability phase. So one way to start off with is to focus on closed kinetic chain exercises. So things like wall sits are great. And this is to improve strength with minimal shear forces on the knee. So when we talk about shear forces, are two opposing forces, right? And we're trying to limit that or reduce the amount of stress that's placed on in terms of shearing force at this stage. Then, as always, we don't just look at the joint by itself, look at upstream and downstream. We start to involve the gluteal muscle groups, the glutes, as well as the hamstrings. And this is to try and optimize the hip mechanics, knee mechanics, and foot mechanics. So we can try and reduce or offload the knee joint stress by making those other areas stronger. So the more hip-centric rotation you have, the more hip-centric power, as in coming from the hips, then less is created at the knee or less has to travel through the knee. And that can make less stress for the knee and therefore assist with the rehab and the recovery process. And then in this phase, we're also thinking about neuromuscular training. So we like to involve proprioceptive exercises, such like balance exercises, single leg stability drills, sometimes even on a balance pad, something to enhance that proprioception. Because again, the more we can get the body familiar with where that joint is and get better identifying that, it's going to get better at controlling it. Then moving on to phase 3, and this is where we sort of term it the functional reintegration, and this is roughly about week 8 to 12 onwards. And this is where we're really going to start to ramp up the loading. So progressive loading, gradual return to weight-bearing activities that they want to do. And this is also where you can start to get a little bit more sports-specific movements for everybody, but athletes in particular. And we're also going to start to introduce some controlled plyometric drills when appropriate. So impact conditioning, a plyometric, the way I like to think about it, which is probably not the correct definition out there, but it's quick force generation and quick force absorption drills, right? So like jumping, landing, those sort of things. So that's a very rough outline and very simplified outline of the sort of 3 stages that we like to go through. But this takes place in sort of a very specific order, and we like to obviously tailor it to the individual, but this just gives you a nice outline of the different phases. So when is surgery necessary? Well, most meniscus injuries respond well to rehabilitation, and surgery may be warranted for a few reasons. There is mechanical locking of the knee due to a large displaced tear. So, for example, that bucket handle tear we're talking about, if there's a really large one and is displaced and caught in that joint where the patient's knee is just locked and keeps locking repetitively and stays locked for a while, even in that case, we'll sort of do non-operative first. But if it's continuing, then we can explore the options of surgery. And then if an individual has failed extensive non-operative rehabilitation and still experiences functional limitations. So again, this is very individual and key to the person as well as the practitioner as well. But if you've not hitting the goals or outcomes that you would expect as a practitioner or that you would expect as a patient or want as a patient, then it may be worthwhile getting some other opinions on it. And then there can also be tears. There is what we call the red zone and the white zone, which is red zone is more blood supply and white zone less blood supply. But that is very, again, case by case dependent. Okay, so the takeaway. The notion that all meniscus tears require surgery is very outdated. So there's a growing body of evidence that supports non-operative rehabilitation as the first line of treatment, especially for your more stable tears and more degenerative tears as well. So if you're dealing with meniscus injury, the best course of action is a comprehensive assessment and a structured rehab plan. right? Wherever this may be, whether you go down the surgical route or the non-surgical route, non-operative rehabilitation, you need that comprehensive assessment and you need a structured rehab plan. Because as I always like to tell my patients, and a lot of good surgeons that I work with will say the same things to the patients, surgery is one part of the treatment process. It's not all, right? So if you have the surgery and do nothing afterwards, your outcomes are probably not going to be as good, right? So even if you do go on surgery, you still got to worry about, the post-rehab and pre-operative rehab, which is becoming more popular. But you've got to have that plan, and that's the key with it, right? And that all starts with a comprehensive, thorough assessment. So make sure you get that done. And obviously, we treat this all the time in clinic. So if you have any questions, feel free to contact us and we'll be able to share more information about it. And hopefully you found this episode quite informative. I wanted to keep it relatively brief as well. Because again, context is key, but I wanted to make these a little bit more shorter for the consumers out there. So it's not a super in-depth by any means, but hopefully you get some understanding that surgery is not the be-all and end-all when it comes to meniscus, and shouldn't, in my opinion, be the first port of call when you have meniscus injuries. Understand a little more about the anatomy and then also the rehabilitation process in a very brief example and explanation. As always, hopefully you enjoyed it. And as we like to say from our end, it's remember to keep learning, keep healthy, and keep doing what you love.